When we combine our clinic experience, the total per employee per month of $762.67 compared to prior year of $618.51, reflecting a trend of 20.9%. One thing that I do want to call attention to is 2 points on this particular clinic experience. The first is the cost. You'll see that the cost is nearly $400,000. That includes admin for 2 months, and our part of our implementation cost is in there as well. So that's why there's such a high number that's causing that cost per visit to escalate. The other thing I'd like to call attention to is the number of office visits. I met with Mary Asher Brandon from Take Care the other day, and we're discussing the calculation of the office visits and how it compared to our experience up to August of this year. And it was identified during that discussion that the way that they were counting office visits was a little bit different in philosophy of how they had been counted in the past. With the prior vendor, they would count the number of visits every 20 minutes regardless of visit type. Take Care had been counting only those appointments that were seen with a nurse practitioner or the physician. So I've asked them to begin counting labs and the other services that we're able to provide through our medical assistants that we weren't able to provide in the past because we didn't have that level of employee inside of the clinic as part of the office visits as well. So we will see that number begin to grow and more appropriately reflect the level of service that we're providing in our clinics. Questions about this? Yes, sir, 520. I'm missing a comma in there. We just received our initial billing from Take Care, and that would include implementation cost and part of our administrative costs for 2 months of service.
So the $35,000 nominal cost and did not reflect.
The September and October is actually billing that we received from the prior vendor.
From the prior vendor.
So November reflects our first billing for Take Care. Questions? Refer to Fund 266. For the month of November year-to-date, we were at $260,016.82 compared to prior year of $250,444.23. And Mr. Good will provide details on November's experience in his report. Motion to approve.
Good afternoon. You should have the report for November in front of you, and of course this is year-to-date from January of 2011. You'll notice for the month of November we had a total of 16 injuries requiring medical attention. For the year-to-date, that brings the total to 222. Of those 222, 155 of them are OSHA recordables. 77 of them had restricted days attached to them. 27 were lost claim days, and 51 were other claims. On the next page, you'll see a breakout, give you the graph of injuries year-to-date compared to the last 2 years. You'll see that that's still pretty much following along a trend. Of the 16 claims that we have, the total net dollars incurred for the month of November was $52,272. Board of Education had 7 injuries. and the total incurred dollars for them was $19,400. The county general had 9, and the total dollars incurred for the county general was $32,872. And the next page, you'll notice we broke down those county general claims into the different departments, and you'll see how the 9 break out there on the last page of your handout. I don't have anything here with me specifically, but some of those deal with the inmates, bloodborne pathogen, where an inmate would spit on a sheriff's deputy and they need to be treated. Also maybe from a use of force. Those are typically the two biggest ones for the sheriff's department. I can get back with you individually if you need more information about that. I guess we're kind of holding our own.
It's about the same as the last year.
Yes, sir. If you really look at it, last year was probably a little bit better year than what it is this year. We're probably compared to where we were about 2 years ago, but a number of things enter into these numbers, and obviously the economic times we're going through and things like that, those are somewhat reflected in these too. Employees, normally where they may not have reported an injury in the past, they can't afford to be out of work right now. They're very overly concerned, and so they make sure they report injuries and things like that now, where maybe in last year they wouldn't have because of the situation going on.
Those claims that are still.
Yes, sir. Some of those claims have been closed as far as settlements and things like that, but because they have open medical, they're open lifetime medical, and as long as the individual is living, there will be claims. And I believe right now, last time we checked, I believe there was 26 that was still open. About that number.
And they'll continue to be open.
Yes, sir. They'll have lifetime medical, so they'll be open until the.
All right, thank you.
Good afternoon. I'd like to give you the report for the fall wellness. We went to our Heart Walk, and this is a community event. It was located at MTMC this year. I'm not exactly sure if the attendance count of the county employees, or there were several hundred people there on October 30th. And I'd like to congratulate Juan Cantro. He was the winner of our Walk Across Tennessee. He won the Xbox Connect, and that was presented at the Heart Walk that day. He works at Community Care. And the team winners for the Walk Across Tennessee also were from Community Care. We had an in-service this Monday night. We had 25 people signed up, but only 3 people braved the rain. So this was about daily play and getting active. And we had a financial fitness Tuesday night with Hops for Cops. They went over home buying and selling and facing foreclosure, and 6 county employees attended that. Our upcoming events, we have diabetes support group starting in January on the 19th. It's a 6-week program. It will be at Lane Agri Park, and will just help you with education of diabetes, planning a meal. At the departments, we are going to have the clinics at Blackman, Stewart's Creek, and Walter Hill. On Tuesdays, you can walk in and get your blood drawn. And on Fridays, you can come back and review those results with a nurse. We're going to take the people that participate in that, the HRAs between January and February, and put their names in a drawing to win gym memberships to MTMC's Wellness Center, which opened their new location on Monday. And in February, February the 3rd is Wear Red Day, so I encourage you to participate in that. And just one last bit of info you may have seen in the paper this week, the America's Health Rankings sent out the report for 2011, and Tennessee as a state ranked 39th, which is really great news. We have been in the lowest 10 for the last 20 years, so even though it's not the best thing to brag about, we are steadily improving. Last year's ranking we were 42, so happy about the 39th. Anybody have any questions? Thank you.
Okay, thank you very much, Kelly. Now, Ms. Benson, are you handling pharmacy co-pays?
That would be me, sir. Yes, sir.
Okay,
There are two sheets in your packet I'll refer you to for this discussion. One is titled Controlling Future Costs. It has the Cigna logo on it. The other is the Preventative Generics Drug List, and you'll need both of those for purpose of this discussion. I had mentioned at our last meeting that I'd met with Cigna back in October, and we looked at what our experience had been inside of the plan from the period of July 2010 through July 2011. One of the things that was revealed in the information that I received was that 32.2% of our population, which is approximately 13,000 people, have a chronic condition, and it drove 62.3% of our over $38 million that we spent during the same time period. And that $38 million only represents what's paid for through Cigna, not our entire cost, including the clinics. Hypertension and diabetes were the two most prevalent chronic conditions that we saw inside of our population. And I think the most staggering thing to me was that of those identified with chronic conditions, 3,698 members had gap in care. And the gaps in care is based on evidence-based medicine, which looks at your labs, your medical claims, and your pharmacy utilization. So someone who is taking a medication who's getting their refills every 45 days would have a gap in care if they're getting a 30-day retail medication. That indicates they're not taking their medication every day the way that they're supposed to. Somebody with diabetes that doesn't get the recommended glaucoma screening, that would be a gap in care. So those would be represented in the number I just gave. Just as a comparative purpose, for the period of July 2008 through June 2009, we had 267 members that had gaps in care. So we've grown by 1,000 members in a 2-year period. Now, how does all this pertain to pharmacy co-pays? Looking at our experience in the clinics and what type of services were being provided and how people were presenting to the clinics for merely free medications and not really in the interest of medical management, I presented the list of medications that we have at our clinics to Cigna and asked them to look at the possibility of us offering those generic medications at zero out of pocket for employees should they go to a retail pharmacy. The reason that we would want to do that is because it would stop the misuse of the clinics, where every time someone presents solely for the purpose of obtaining free medications, it costs us $36 that we talked about last time in the labor fees. When I reviewed the Cigna data and I saw the gaps in care and the percentage of individuals that we have identified with a chronic condition, it compelled me even more that we need to provide an offering to employees that would create an environment where they were compliant with prescribed plans of treatment, including their pharmacy. Cigna already has a program in place. That is what you see on the preventative drug list that I provided to you in your packets. These medications replace or also are available in our clinics currently. So we were able to actually take the list that our current clinic offers and have those medications found already on the existing list established by Cigna. And it addresses some of our top chronic conditions that we see in our population. Blood pressure medications, diabetic medications, cardiovascular disease medications, as you can see here on the list. What I'm asking of the committee is to consider approving where we can implement the preventative generic drug list at retail and mail so that our employees will at least at the very minimum, they may not go for that glaucoma screening if they're a diabetic, but at the very minimum, let's get them compliant on taking their medications in the intervals that the physician has prescribed. And if we remove that financial aspect out of it, I feel that they will be more compelled to do that. The return to us is that we'll have a healthier population and that the conditions won't exacerbate to the extent that they are right now. Once someone in our population enters into what is called a catastrophic claim for the period that was in review, the average spend rate that we see for that individual is around $233,000. So not only are we going to have to do things like this, but in the upcoming plan year that we look at for 2013, we're going to have to do other things inside of our plans to get our population healthier and more engaged in taking care of themselves so that we can continue to offer affordable health plans.
Okay, she's told us quite a little bit there, and I'm sure you must have some questions. Who'd like to ask some questions? Now, right now, where do you say that these our employees are currently getting these types of drugs?
If they are under the medical management of the staff at our clinics, they can get drugs in these drug classes free through our clinics. We know that we have a problem with the appointments, so not everybody can get in to be seen at our clinic. But the bigger problem is that we have had to re-educate people that the clinics are not walk-in pharmacies, that unless you are under medical management of the clinic staff, you cannot schedule an appointment to come in to get refills of your medication. We would not want to create that type of environment where we are doing pharmacy refills for conditions outside of our medical management. There's numerous reasons that we wouldn't want to do that, such as we wouldn't have pharmacy edits and some of those things that you get as efficiencies through a retail or mail order pharmacy.
So they can currently get these same drugs through the clinics at no cost. Is that correct?
They can get these same drug classes.
Same drug class.
So as an example, on the cholesterol medications listed in the Cigna list, it's a more expanded list. We offer a more defined list of this drug class inside of our clinics.
Put this in place and make this available, and this list can be obtained from any pharmacy.
That's correct.
Retail or otherwise. Do they still have the option of going to the clinic, or do they have two approaches they can now take if we do this?
There would be two approaches. They could still go to the clinic. And, there may come a time where if we do implement this, that we want to look to say, okay, do we still want to offer these same type of medications at the clinic? What would be our value in offering medications at the clinic? There are some medications currently at the clinic that aren't on this list. Acute medications such as antibiotics are not on the preventative generic list, but they could still obtain those free through the clinics. This is just focused more on chronic conditions.
Chronic conditions. Ms. Harvey, I believe you would like to say something.
I do. I have a question. You said that Cigna already has this available. Will this cost us, the county, any money to implement it?
The only thing it would cost in terms of the county would be the amount we've been collecting on copays and deductibles. But in terms of administrative fees from Cigna, no. My comment that they already have this in place is that they're doing this for other clients. This is a pre-established list that they can extend to Rutherford County for implementation.
Other questions or discussion? Ms. Dickerson.
I want to make sure I understood you right. We offer this list at the pharmacies basically free. We're not having the $5 generic copay. We're looking and hoping to free up some of the appointment times that are being taken up by the folks coming in with a prescription, trying to get it from another doctor, the prescription from the other doctor wanting to get it free there, whereas we could free it up so that our employees that are sick can get into the clinic for that, and then that person that has the script from another doctor can just simply take it to the drugstore and get it, which actually saves us the $36, $37, and it does free up some appointment time. That was my understanding. Okay.
Okay, other discussion. It seemed like it's a win-win, and your first thing you started this on is on the journey is trying to people with chronic conditions, get them to take their medications consistently. Ms. Harvey?
Is this something that if we voted on that we could start implementing immediately, or would we have to start until like January the 1st?
January the 1st would be the earliest we could implement this.
Oh,
Just to kind of review what Mary was talking about, whenever I was thinking about back when we first implemented the Care Here and stuff, we were, at the time, we were talking about the generics. It would save us money if when they're at coming to the clinic to have a visit, the generics that they were able to purchase there and be able to have there, to go ahead and dispense those. So this wouldn't, that's what she was asking the same thing. I just want to make sure this wouldn't affect any of that.
Sure.
This is just where a person has a doctor's prescription from their doctor somewhere else, and they were using the clinic as a pharmacy to do it? Okay.
All right, so like we talked about last time, I know that was the selling point on the pharmacy. I've not seen anything that shows that the labor cost associated was ever calculated in. Whenever I was doing my review for this recommendation, I looked at what is the cost of our medications through Cigna versus what is our cost through the clinics, and I really found that they were similar on the small set that I reviewed. And so the county is not really incurring a substantial cost by shifting this into the health plan. And so we're not really losing on that efficiency that you are describing. What we are saving on is what Ms. Hickerson referred to, which is people who come to the clinics, such as a retiree that sent me an email last week that said the only reason that they take the county insurance as a retiree is so they can get free medicine from the clinics, but they don't get their medical management there. And so we've sent out many communications about the clinics are not walk-in pharmacies, and we will only refill medications for which you are under our medical management for. But what's happened is people are not responding to those communications, so we're having to do one-on-one education, and that comes at a cost to the county.
That's what I just want to make sure. And then I wanted to, whenever we started the Care Here clinics, we did a really big push for those health risk assessments, and I was just curious if enough time's gone by now, there's new people coming and going and stuff like that. And I know that we talk about it a lot, but I don't know how much of a push there is at some of the places to make sure we get those all done again, where we can catch the people and where they can get care and be helped before they have a heart attack or a diabetes or something like that takes off. But I don't know. I mean, your HR and stuff, they're the ones that are good at that and stuff. So.
Ms. Perrin spoke to the fact that we are having an HRA clinic starting in January that will last January and February. We're going to do a drawing for prizes to incentivize people to come in and get their HRA. It will be held at the clinics. And, just like with the flu shots as an example, people were accustomed to us doing flu clinics throughout the different locations around the county for the convenience of employees. And when we didn't do this year, I got some criticism back. But what we found is that really having it at the clinic with the expanded hours of the clinic, we got a much better response. In addition to the 800 plus appointments that we saw with nurse practitioners and physicians, we gave out over 1,300 flu shots this year. In years past, we averaged around 700 to 750. So I hope that we'll see the same thing with our HRAs. We do for our population, for the number of appointments available at the clinic, we do have a pretty good turnout on HRAs throughout the year, and we hope to start the year out with an HRA clinic where people are mindful that, it's a new year and all the New Year's resolutions, and maybe this will incentivize them to include this into their workout or diet or whatever it is that they do.
okay, any other questions or comments? We need a motion to accept the recommendation to put in place a preventive generic drug program through Cigna Sandvig is second. Any other discussion? All in favor, then please say aye. Aye. Any opposed? Thank you very much. Now we will talk about option 1 and the 2013 premium rates.
I think that we have clinic hours on there first. Provide an update to the committee.
Too quickly
That's
there.
okay.
Clinic hours. She's just going to make an announcement here, I think.
As we are continuing to look at what were the concerns that were brought forth, both by the prior vendor and the feedback that I'm receiving currently, we are working every day to address the concerns of the employees. But one of the things that has been consistent is the number of available appointments. And the only way that we could address that would be to add more hours into the clinic. If we don't add more hours into the clinic, then those costs stay inside of the health plan through private practice physicians and other clinics that employees choose to use. So we are going to be expanding our clinics by 40 additional hours after the first of the year. We are currently in the process of recruiting for a new nurse practitioner and a medical assistant. The expansion will occur primarily at Stewart's Creek. It will enable us to run Stewart's Creek right now. What we have projected is from 7 a.m. to 6 p.m. Monday through Friday. With 2 providers there most of the time. So that will allow us an opportunity to better address the needs of our employees. And I just wanted to make the committee aware of that.
And Ms. Stinson, are we able to do that at no additional cost? How is this working?
Well, it's just a cost shift. The costs are currently inside of our medical plan because they are presenting through Cigna. So I met with Ms. Nolan and talked about our need to expand the clinics. And through that discussion, we talked about how the costs are already there. It's just where do we want to spend our money. So yes, there would be additional costs as it pertains to the management of the clinics. But if the money is already being spent by Rutherford County employees. It's just, where is it coming from?
Okay. All right. Any questions on that? That should be good news to all of our employees. Now we will then be ready for the discussion on option 1 in the 2013 premium rates.
I have a list there, or a piece of paper for you called medical enrollment shifts. I know we just finished open enrollment for 2012, but in my role immediately I have to begin looking at the next year as we set rates and make sure that rates are established with budget and everything. We talked about, and I did send out a letter to option 1 participants prior to open enrollment, encouraging them to look at their utilization of the insurance, what they're paying for premium, and compare that to other options available. From that letter, we had a response that was tremendous, and 72% responded by moving to either option 2 or option 3, leaving 237 people in option 1 effective January 1 of 2012.
Your paper, it says 156. Did I miss?
Oh, you're looking at a different year. That's broken out by type of employee.
I got it. So you have to go all the way across to the total.
Correct.
Okay, excuse me.
That's okay. I've done a preliminary review of the rates, and last time whenever we looked at rates for 2012, option 1 needed a 32.6% rate increase with a expected trend of 11% built in at that particular point. It was the recommendation that we hold flat and use the premium pool to subsidize the experience in the plan. But as our population continues to grow and the number of claims and the cost of the claims, it's going to be more important for us to continue to start to collect appropriate premium amounts. Option 1 for 2013 is projected to need a rate increase in excess of 60%. 60. When I look at the necessary increase and the difference in option 1 and option 2, which is basically $200 in deductible and $500 in annual out-of-pocket cost, it becomes cost prohibitive for us to offer option 1 beginning in 2013. It's not the amount that the county would contribute to that plan, the amount that employees would pay out of pocket if we were to take an appropriate rate increase. what needs to occur is that we look at different plan options for 2013, and it's the recommendation that we no longer offer option 1 beginning in 2013. That doesn't mean that our current option 2 and option 3 will be the only plan options. Once we have a couple more experience built in and I can better see where we are in terms of rate increase for option 2 and how option 3 is trending, then I will go in and build another plan option for your consideration after the first of the year. But option 1 has just gotten so costly to both the employees and the county that we need to do a better job of doing cost sharing at a more appropriate level.
Sir. Mr. Hester.
If we go back to the initial insurance report, we can look and see that the trend this year is terrible.
Right.
Okay. Have you done any analysis if we pulled option 1 out of this year's results? What would it look like? Have you done anything like that?
What I have done is talking about based on the enrollment. So basically those additional 237 people would roll over into option 2 or option 3. Are you talking about that? Actually, we did. We went in and we looked at what it would mean if we still had option 1, 2, and 3 in 2013, and then what would it mean if we didn't have option, or if we had option 1 based on the expected enrollment levels for 2012. What we see is that option 3 continues in both scenarios to be overfunded, and we know that that's where we've been creating the premium pool to help fund option 2 and 1 for the past several years. We do find that it causes option 2, and again, there are some variables that haven't been finalized, such as experience. We still have a couple more experience we need to build in, and also all of our medical is out to bid currently, so some of our administration costs could lower, which would affect the premium rate. But it does cause the increase in option 2 rates to go about 20 points up.
Do we think that the reason option 1 is so adverse is because the people who are utilizing that plan are the ones that are incurring, they have the conditions where they know they're going to incur a lot of cost? So do we have an adverse selection?
Right, that's correct.
And how's that going to affect, if we eliminate it, you've taken that into consideration in your projections on class 2 and 3?
Right, so what would have to happen is we are adversely selected against option 1. Some members made the decision to go ahead and move in 2012 based on their review. In 2013, it will be incumbent upon us whether we keep just the 2 plan options or we add an additional option, is that we get to a mandatory meeting where people would be required to come and hear from the insurance representatives prior to open enrollment. And the reason that we would want that to occur is so that people are actually assessing their medical utilization and choosing the right plan. We do have some people in option 1 that are there simply because it's the lowest out of cost, and people can budget to expected cost, but they can't budget to the unknown. And so just like with our chronic conditions, one of the theories I have is that people aren't treating the way that they should be because of the co-insurance arrangement. On our office visits, it's 80% after deductible. Well, if I live on a very tight budget and I'm not feeling well, if I don't know what my 20% is going to be, I'm not going to go to the doctor because it can make a difference between me being able to buy groceries the remainder of the week. So I think that we need to go in and structure a few things differently to address the concerns that you're bringing up, because yes, you can always have adverse selection inside of your plan. Once we don't have option 1, those expenses are going to move to one of our other plans. It is going to cause rate increases to need to be there, but we also already needed to take a rate increase in option 2 last year and remained flat using the premium pool because we had excess premium being collected out of option 3.
So what you're proposing is you're just sort of giving everyone a heads up that you really need to do some more study and come back with maybe some additional options, but in advance, you really think that you probably already know that we shouldn't continue with option 1.
That's
You
correct.
don't know what the other replacement options might be yet. Is that correct?
That's correct. So the reason it's important we go ahead and make a decision about option 1 is because we'll have to build in assumptions about those 237 people as we're looking at rates and we're making recommendations for future years.
Harvey?
Currently offer option 1 to our retired employees? And if so, how will that affect them?
We currently offer option 1 and option 2 to our retired employees. The way that it would affect them, it'd be just like any active employee. In 2013, they would either have to elect our current option 2 or the other PPO option that would be made available.
Mr. Sandvig?
What are some things, some possibilities if we do wind up with another option?
Right. So one of the things that I looked at or had considered when I came to the county at the very first is in looking at the claims experience inside of option 3 is that probably more people would benefit from being in option 3. I think the wild card of option 3 for most people is the pharmacy. Depending on what medications you're on, option 3 isn't a viable option. People who are on high-cost drugs, it can get very costly to them to be in option 3. So initially I had thought that we would build a plan with a $750 deductible so that it would allow them to be in the security of a PPO with the benefits of the pharmacy, having the, with the set copays, and they could actually better gauge what their out-of-pocket costs are before jumping into option 3. But in looking at part of the problem between option 1 and option 2, which is they're so close in terms of the benefits, I'm not quite sure based on what we're seeing in our experience both for last fiscal year and current fiscal year, if we don't need to do something that has a wider spread to it. And part of that determination will be once we know if option 1 will be offered in 2013, some of the assumptions that we will make in reviewing the plans and what those impacts are. If we need to go to a $1,000 deductible, that may be attractive to some people as if most of their cost is in the pharmacy. Adding a copay for office visits would be attractive to people, and it would be a valid exchange for a higher premium or higher deductible cost. So there's different things like that that's on the agenda to be reviewed.
Ms. Stevenson.
Would it be safe to say that if we voted to keep option 1 as it is, that there would not be an alternative plan? The only way to receive an alternative plan is if option 1 is not on the table anymore, which would give you the ability to come up with something different and more unique to meet our employee population?
I think that it becomes, insurance is intimidating to most people anyway, and I think that having 4 options would be a difficult scenario to get a proper response from the employees from. So if we still had option 1, then the question becomes to the committee, what are we willing to do in terms of rate increases to continue to keep the fund at a level that makes us fiscally responsible? But otherwise, you are correct in what you're saying.
Nolan.
Healthcare reform, aren't we supposed to? The premium reflective of what the cost is. So if you put a 65% increase and offer option 1, I'd say your participation will be very highly selected, but you might have 2 people in it.
And the struggle, know, there is a financial role to what I do, and then there's also the human side to what I do, and I care equally about both. And it bothers me knowing that people don't always take care of themselves the way that they should. It would really bother me for us to take such a substantial rate increase, because you are correct. Some people would just, out of creatures of habit, would go ahead and stay in option one, just like they did whenever we took the substantial increase last time. And they don't do the math that shows that, you know what, I am paying $1,600 more for $700 in benefit by being in option one. I would rather us develop a new option that is more attractive, both in terms of the benefits and in terms of the associated premium. But most importantly, I'm trying to make small steps inside of our plan so that we don't end up somewhere like with the state, which had to make substantial changes in what they offer to their employees, and cause them to kind of go through some difficult open enrollment, as they had to get out and re-educate everybody on what the various plan options were going to be.
Ms. Stinson, what do you want us to do today?
Today I'd like consideration of the committee for option one for 2013, to know whether or not they want to continue to offer this to employees in 2013, because it will be dependent upon that answer as to what we begin to do in terms of determining recommended rate increases and plan modifications.
So you're wanting us to go ahead and accept your recommendation that we not have option one beginning 2013?
Yes, sir.
Subject to you providing us some reasonable alternatives that would make the plan complete and hold. All right, that's sort of where she wants us to go. I guess none of us believe, and I don't think you're suggesting that we just do away with that one without replacing it with something else or modifying the others to make the whole program even a stronger program.
Correct.
Is that correct? Ms. Hickerson.
I'll be willing to make a motion that we go ahead and do away with option one starting in 2013, and have Ms. Stinson come back to us. I know it'll probably take more than having it for next month or even the next, but as soon as possible, get us some good options that we can go ahead and start figuring premiums, because I know we'll have to have an idea to start next fiscal year, which is coming around pretty quick. So I'd make the motion to do away with option one and look into adding us another option that is more feasible for our premiums and our cost to our employees.
Okay, do we have a second? Mr. Hall, other discussion? All right, we're ready to vote. All in favor of that, please say aye. Aye. Any opposed? Okay, so you have a lot of work ahead here to work on a very complex set of matrices, say, in this discovery. Okay, any other business to come before this group? If not, thank you very much, and we are adjourned.